Good afternoon, everyone. For those who don't know me, my name is Li Liu. I'm an associate professor in the department. I'm also the lead of the population and health area of interest. So today it's a great privilege and honor, really, actually, to have Dr. Abhirup Datta with us today. And this is actually not only what Pop and Health is sponsoring, but also we have some colleagues probably joining from Hopkins Population Center as well. So I'm really delighted to be able to introduce Dr. Datta today. And he's an associate professor, newly promoted. And well, congratulations, it's you, yes. In the Department of Biostatistics in our school. Prior to joining Hopkins in 2016, he completed his PhD in biostatistics from University of Minnesota. One of his primary ongoing research interests is to develop Bayesian models to improve estimates of cause-specific mortality in low and middle income countries. And in particular, Dr. Datta is part of the countrywide mortality surveillance for action, or COMSA Mozambique project, which aims to produce neonatal, or actually national estimates of mortality for under 5 and neonates. And verbal autopsy, as many of you know, is one of the primary tools to actually obtain cause of death information in such a low resource setting. However, it is subject to a bunch of different biases. So what Dr. Datta's work has been is to develop Bayesian VA calibration methods to produce bias-corrected cause-specific mortality estimates. He actually has been also recently awarded a separate GACE grant to work further on this, to extrapolate what has been learning from the Mozambique experience to many other countries. And also, we have the great pleasure and honor to work with him as well as a collaborator on our new GACE grant on child and adolescent cause of death, or the CA code project as well. But let me say a bit more generally about his work in case you're interested to either collaborate or actually have a discussion. So in general, his research focuses on developing Bayesian hierarchical models for multiple sources of data with application in both global health and environmental health as well, with specific focus on spatial models for geographically indexed data. And his research has been funded by the principal investigator grants from the National Science Foundation and the National Institute of Environmental Health Sciences. He has received the Early Career Investigator Award from the American Statistical Association section of Environmental Health and the Young Statistical Scientist Award by the International Indian Statistical Association. So please join me in welcoming Dr. Datta.
Thank you, Lee, for the invitation and for the very nice introduction. And thanks, everyone, for attending. As Lee mentioned, my talk is about developing hierarchical Bayesian models to correct for misclassification accuracy of verbal autopsies, which is one of the main instruments for getting cause of death data, but it's sort of inaccurate and uncertain. And so the talk is to sort of correct for those and produce improved estimates. So at any point, if anyone has any questions during my talk, please feel free to ask me, and I'll be happy to clarify. So this work is joint work with several people in the Biostat department. My collaborators are Jacob Fixel, who was my former PhD student, Brian Gilbert, who is my current PhD advisee, and Scott Ziegler, who is my fellow faculty and collaborator in Biostat. And in the International Health Department, this collaboration is with Agbese Amozu, Robert Black, Emily Wilson, Henry Coulter, and the entire COMSA Mozambique team. And that's the main project that I'm going to be talking about today. And this work is funded by 2 grants from the Bill and Melinda Gates Foundation. The main grant was on the COMSA project in Mozambique, with Agbese being the PI. And then, as Lee pointed out, we recently received another grant to sort of specifically expand on the statistical aspect of the work and extrapolate it to other countries. So if you're not familiar with verbal autopsies, basically many countries, especially low and middle income countries, often do not have fully developed civil registration and vital statistics, or CRVS systems. and full autopsies or sort of proper medical certification is not conducted for majority of the deaths. And so it's challenging to estimate what we call the population level cause-specific mortality fractions, which is simply within an age group, what percentage of people are dying from specific causes. And this is a very important piece of information that helps to generate like global burden of disease estimates. The CSMS also helps understand which disease to prioritize and over others and stuff like that. So it's a very important piece in health policy and resource allocations. So verbal autopsies, in absence of like more comprehensive cause of death data, verbal autopsies has become like the mainstay to get information about cause of death in many countries. What it does is it's like a survey, it's like a census of the disease of the deceased. It's like the government or the program sends out field workers to homes and they do a survey getting information from the relatives of the deceased, and that survey is very systematic. It has like a formatted questionnaire, and that has questions about like the background information of the individual, like the health history, and a lot of questions about like symptoms that were manifested before the death. So there are like some sample questions here. The World Health Organization has standardized the verbal autopsy tool, and they come every few years. They kind of review and revise the tool. So, for example, the 2016 version had around 200 to 350 questions based on like the age group. So there are separate modules in the tool that are for different age groups. And I think very recently they have come up with a new instrument that has tried to sort of streamline the number of questions. If you are interested to learn more about verbal autopsy, there is a page in the WHO website about that. So the verbal autopsies are not cause of deaths. They are just like a bunch of responses to the questions asked. And to get a cause of death from verbal autopsy, they're passed through algorithms, what are referred to as like the computer-coded verbal autopsy or CCVA. So these are basically algorithms, or from a statistical perspective, you can think of these as classifiers that input this like very high dimensional or very large survey and output a cause of death. So you can think of this from a statistical perspective as basically high dimensional classifiers. And there are several very well established verbal autopsy algorithms. InterVA by Peter Bias was one of the most famous algorithms. In silico VA, developed by Tyler McCormick in a JASA paper. They sort of like do a more systematic, statistically principled treatment of InterVA, and it's kind of preferable over InterVA in terms of the underlying statistical principles. Tariff is a very different method that's proposed by the IHME, and there are a bunch of different methods. There are also like you can also use generic statistical or machine learning classifiers like the naive-based classifier or any other thing like random forest or neural network or anything else really. And if you want to read up more about these classifiers, openva.net is an excellent resource that talks about some of the major classifiers and discusses the pros and cons. So focus on the COMSA Mozambique project. So this project, I think it started in 2017. Its main goal is to sort of generate and continuously update data on the cause-specific mortality fractions, or CSMFs, at national and subnational level at Mozambique, with particular emphasis on like trying to better understand neonate and under 5 children mortality within each cause category. So what COMSA has collected over the last few years is a large database of VA records for under 5 children and neonates, and also for adults, but this talk primarily focuses on children and neonates. And so they have sent field workers out and they have like got the VA responses. So basically from COMSA, we get a pretty large data set of only the VA responses, like questionnaires. And for majority of these deaths, we don't have any other more comprehensive information about their cause, like not coming from medical autopsy or like a panel of physicians deciding on the cause of it. It's just the verbal autopsy that we have. So when we started working on this project, we knew that there were like verbal autopsy softwares out there that can give us a cause of death starting from the questionnaire. And we thought that, okay, this is a simple enough project. We'll pass each record through one or multiple of these software, get the predicted cause of death, and simply aggregate that to get the cause-specific mortality fraction. That seems like a simple enough exercise. So this is like a toy example where we have only the verbal autopsy records. We pass it through the software, get the predicted cause of death. In this example, 3 out of 6 are predicted to have died of HIV. So then the HIV CSMF is 50%, and similarly for the other cause categories. So that seems like a simple enough procedure. We went ahead and did that, but then we wanted to understand how reliable are these estimates? Can we really trust them? And to sort of understand that, we need a secondary source of information and more comprehensive information about the cause of death, against which we can cross-tabulate these verbal autopsy predictions and see how accurate they are. So that's where the CHAMPS project comes in. So CHAMPS is an ongoing project in several countries, including Mozambique, where they're doing what is called like a minimally invasive tissue sampling, or MITS, on a very small set of deaths occurring within the CHAMPS sites. So MITS is basically a combination of like pathology and laboratory tests, as well as looking at health history and clinical records. And then it's kind of a panel of physicians look at all the data and they sort of come to an agreement about what the possible cause of death is. So it's a much more comprehensive process to get a cause of death than just looking at the questionnaires from verbal autopsies. And it has been shown previously that the MITS cause of death assignments can be reasonably accurate when compared to full diagnostic accuracy. I think the reported number was around 75% in this paper, but definitely it's a more comprehensive process. It may have its own set of issues, but for our purpose, because the CHAMPS project had data in Mozambique, and it's definitely more comprehensive than the VA, so we wanted to use the MITS data to understand how accurate really is the VA. So what we did was we kind of paired up the MITS cause of death and the VA predicted cause of death within the CHAMPS cases. So now we have a much smaller paired data set compared to the much bigger VA-only data set. And from this data set, what we looked at that within each cause category, what proportion of those cases are correctly specified by the VA. And so we can get this sort of an error matrix or misclassification matrix where the diagonals give us an idea of like how accurate the VA is for that specific cause, and the off diagonals will give us an idea of like what proportion of cases are being misclassified for that cause. So this is an example of that error matrix in Mozambique, and based on the CHAMPS data for one of the VA algorithms, in silico VA, which is again very popular. And as you can see, if you look at the diagonals range from around 10% to maybe up to 50 or 60% at best, which shows that they're far from being like fully accurate, and more often than not, they're like accurate less than 50% of the time. So if we just do the procedure that I showed above, pass through the VA algorithm and just aggregate to get the predicted cause-specific mortality fractions, it's very likely that we are going to end up getting biased estimates. So, and also like this is not just like a one-off case of large misclassification rates. We have looked at different choices of VA algorithms, different age groups, and also we have looked at a different data set which has a gold standard information that's different from MITS, which is the PHMRC data. I'll talk about it later in details, but the consistent finding is that VA is generally pretty inaccurate. So just to illustrate the issue of why a misclassification bias would lead to resulting bias in the cause-specific mortality fraction. So this is a toy example where this inner color or the solid color gives you the true cause of death. And you can see out of 10 people, the numbers in the respective color categories are 2, 3, and 5. So the true cause-specific mortality fractions are going to be 20, 30, and 50%. And then, but the problem is we are not getting to see these in the VA data. We only see the predicted cause of death. And they can agree with the true cause of death for a certain set of individuals, but they can also disagree for some other set of individuals. And you can end up getting an estimated cause of death from verbal autopsy, which is different from the true cause of death. So this is a toy example that sort of sums up what we do as VA calibration, and then we will go into the details. So here is, we just consider two cause setting, like the two causes are orange and purple, and there are 10 individuals, 8 of them dies from cause orange, 2 of them dies from cause purple. So the true cause-specific mortality fraction would be 80% for cause A or cause orange and 20% for cause B or cause purple. But unfortunately, we are seeing just the predictions from the verbal autopsy, and we see that like 6 of them are predicted to be from cause B and 4 of them are from cause A. If we had the idea of what the misclassification rates are for the VA, so for example, if we had the knowledge that for cause A, only 50% of it is correctly predicted by the VA, and the rest 50% are being predicted into cause B. And then for cause B, the VA is very accurate. It accurately classifies 100% of them as cause B. Suppose we had this additional information, then these 2 pieces of information, the predicted causes from the VA and the knowledge of the misclassification matrix would be enough to kind of back solve and get the true cause-specific mortality fraction. And to do that, we can write down, this is just the law of total probability. Like if PA denotes the true proportion of causes, true proportion of cases dying from cause A, then what we are observing, the 40% number, is just 50% of PA, because we know only 50% are being correctly classified, and then 0% of the proportion of cause B, because none of the cause B are classified as cause A. And we have a similar equation for the second line, and we end up with 2 equations and 2 unknowns, and we can solve for that and get the correct answer, which is 80% for cause A and 20% for cause B. So this is basically the underlying principle, that if we get the marginal probabilities for the biased VA and we get their conditional probabilities of being biased, we can back solve and get the true probabilities for dying within each cause category. Okay, so and when we can easily generalize this to more than 2 causes, you cannot sort of solve for it manually. You have to sort of resort to automation. But the underlying principle is the same, that the uncalibrated CSMF, or the one that we observe, can be written in terms of the unknown calibrated CSMF and the error matrix. And if the error matrix is known, so you have this is known and this is known, and you are basically solving for the calibrated CSMS. That's the main principle of the VA calibration. Any questions up to this part? Yeah, that's a very good question, and that's what this slide is about. So the question is, how do we know the error matrix? We really don't. So all we can do is really make a best guess based on the data available to us and clarify under what assumptions can we call this as the error matrix for the VA. So what we did in Mozambique, as we said, we had the data from the CHAMS project, which has not only the VA, but also the MITS diagnosis. And so we can create these misclassification matrices. So each row of this matrix gives the MITS cause. So the rows gives the MITS cause and the columns gives the VA predicted cause. So you can see for malaria, 44% of the 48 cases were correctly identified as malaria by VA, but then a bunch of them were identified as pneumonia, a bunch of them were identified as other infections, and so on. So we have this is a much smaller data set than the raw VA data set, but using this data set, we can estimate a misclassification rate for each cause pair of the VA. There are several underlying assumptions going into this. The main assumption is that there are two main assumptions. One is that the MITS is reliable, like it is the gold standard, and as I said, that it has shown to be reasonably accurate, but it's not fully accurate. And at least in this work, we don't adjust for that. We assume the MITS to be the truth. The other assumption is this is the misclassification matrix estimated from the joint, like the CHAMS data, which has data from many sites, including Mozambique. And so the underlying assumption is that these misclassification rates or the conditional probabilities kind of stay the same across different sites or across different countries. So that's also a major assumption. That's something that we need to assess in the future. But yeah, so for now, this is the data set that we use to estimate the misclassification matrix. Okay. So the hierarchical Bayesian modeling that we do, we have two pieces of information. We have the larger data set from COMSA Mozambique, which has only the VA data and no other gold standard cause of death data. So we model the VA predicted counts as a multinomial distribution with the generating probability to be the raw CSMF that we get from the VA. So this is the VA predicted counts will be biased. So we are modeling them to be multinomial generated from the biased or the raw CSMF. And then for the CHAMS data, we have both the MITS cause and the VA cause. So within each MITS cause, we model the VA predicted counts as a multinomial distribution, which is generated from the like for cause A, it will be generated from the 8th row of the misclassification matrix, because the 8th row of the misclassification matrix is really giving you the probabilities that the VA is giving some cause B, given that the true MITS cause is cause A. So we use the 8th row of the misclassification matrix to model the CHAMS data. So there are two pieces of information, and so we can nicely combine them in a hierarchical Bayesian model. To do this, the reason we do hierarchical Bayesian modeling, one more reason we do hierarchical Bayesian modeling is that if we go back, we have typically, at least now, we have around 500 MITS cases across all sites within each age group. So that's a very small sample size. And so these are the proportions that we see in that 500 cases, but you can see this is a 7x7 matrix. So there are 49 cells. So the 49 cells are being estimated from like a data set of size 500. So the estimation is not going to be very stable. So there is more data collection going on with MITS, but for now, we want to make sure that we don't end up getting very unstable estimation rates. So we don't use the raw rates as we have here. We kind of like shrink them or move them towards like towards the diagonal matrix or the identity matrix, because we think that in absence of evidence that the VA is biased, we should trust the VA. So the smaller the sample size, the more it will move towards like the uncalibrated estimate. As we get more and more data, it will move away from the uncalibrated estimate and get a fully data-driven estimate. So as the sample sizes in these ones grow larger and larger, we will move more away from the assumption that the VA is accurate and use the data-driven misclassification matrix. But for smaller sample sizes, specifically towards the start of the project, we had to resort to like shrinking them considerably so that we get stable estimates. So that is also convenient to do in a Bayesian setup. We can just simply add priors to the parameters. Okay, so this is the overview of the whole calibration process. We have two data sources, the larger VA data and the smaller VA MITS data. We pass them through the CCVA softwares to get the predictions, aggregate them to get the uncalibrated or the raw CSMF. We use the paired data to estimate the misclassification matrix. We combine the two using the calibration equation, which is simply the law of total probability. We have the uncalibrated CSMF is calibrated CSMF times the misclassification rates. And so because these two pieces are known, we can solve for the calibrated CSMF. And we do this in a Bayesian setting by adding the shrinkage priors that stabilize the estimation, and we get a final estimate of the cause-specific mortality fraction. Yeah.
Can I clarify? So for the uncalibrated CSMF, do you average all the different algorithms you use?
Yeah, that's a very good question. So the question is, which algorithm do we choose? Do we choose one of them, or do we combine the algorithms? I'll come to that later in the talk. Yeah. Yeah, that's also a very good question. So correct. Yeah, it's the immediate cause of death, but the underlying cause of death is probably the sepsis you mentioned. Sorry, the pancreatitis. So the VA predicts the underlying cause of death, and the MITS gives you the entire causal chain. So it starts with the underlying cause of death to the immediate cause of death. So we match the underlying cause of death from the MITS to the underlying cause of death from the VA to make the assessment kind of comparable, because the VA only predicts the underlying cause of death. But I'll come back to your point, because sometimes the MITS leveling of immediate and underlying is not very accurate, and we have a piece that adjusts for that. Yeah.
Also, are there certain causes of death that are more often misclassified, and how does that get determined in the whole calculation process?
Yeah, of course, you can see that not all causes of death are equally misclassified. So for example, for diarrhea, I think around 60% are getting correctly classified, whereas for other infections, it's around 26% here. So when you do the calibration equation and solve for that, it is accounting for that underestimation, that other infections are being undercounted to a greater degree than say for pneumonia here, and that would the calibration accounts for that. Okay, so then I'll talk about the different extensions to this, and then hopefully that can address some of the questions that were asked. So the first extension was to account for multi-cause VA data, because some of the algorithms, they don't just give you a single cause of death, they actually are probabilistic classifiers, and they give you an entire score for each death, that what are the probabilities that it belongs to each of the cause categories. So essentially, like classifiers like INCICO VA, Inter VA, you don't get just one cause. For each case, you get like this entire row, which says 70% from HIV, 20% from malaria, 10% from sepsis. This is completely a made-up example. What we do to convert it to a single cause is we use the plurality rules. We use the one with the top cause, assign that as the cause of death. That, of course, leaves out information. So it is maybe fine to assign this case to HIV because it has 70%. But if you look at this one, it has 45% for HIV and 35% for sepsis. If we completely ignore this, and if there is some cause, which is always the second cause, and we always take the top cause, that cause will be completely left out. And so that can also lead to bias in the estimation procedure. So you can see if we take the plurality rule, the top cause CSMF will be like this. If we average the scores, the top cause CSMF will be like this, and they're different. And so there is much more information in using the entire probability scores than using just the top cause. So that's a very simple way that what we want to do is we want to use this whole thing instead of using the top cause. And to do that, it's fairly straightforward. So we take an individual whose, say, true cause is orange. but the VA predicted score is like 20% orange, 40% green, 40% purple. What we do is we create 10 copies of that data for that individual. And for 2 of the copies, we assign the VA predicted cause as orange because 20% was orange. 4 of the copies, we assign the VA predicted cause as green and 4 as purple. So we create 10 copies of that record. And then for each of them, we do a single cause analysis. And since we're artificially inflating the sample size by 10, we downweight each of the records in our model by 1/10. So that's how we can adjust for a probabilistic VA prediction by simply using a weighted likelihood. Okay. Before I go to the other extensions, I'll just present some validation of the method on the PHMRC data. So the PHMRC data is like the only gold standard data available to for validating any new method for verbal autopsies. It's a data collected in 4 countries: Philippines, Tanzania, Mexico, and India. And it has both the verbal autopsy, but also a more comprehensive gold standard cause of death, also based on like laboratory pathology and clinical endpoints. So what we did was we took the PHMRC data, we trained the verbal autopsy algorithms on 3 of the countries. And from the 4th country, we only took a small size of the data to estimate the misclassification rates of the verbal autopsy algorithm that was trained on the other 3 countries. And then we compare just the raw predictions from the VA, which was trained on these 3 countries, versus the calibrated prediction, which is using a small slice of the data from the 4th country to estimate the misclassification rates and adjust for it in the calibration. And we do this, we repeat this by taking different slices of the data. We rotate the countries. So here, India is 4th country in the example. We do this for all the 4 countries in rotation. We use the adult data for PHMRC because it had the largest sample sizes, but the method is not specific to any age group. It works for all age groups as long as you have gold standard data. These were the sample sizes. We grouped the causes of death into these 5 broad causes. To validate the method, we look at the validation matrix called the cause-specific mortality fraction accuracy, which basically measures the similarity between the true cause-specific fractions and the predicted cause-specific fractions, either by the uncalibrated CSMF or the calibrated CSMF. And this measure lies between 0 and 1, with 1 being like higher being better. And it's formulated in such a way that it places more importance on more prevalent causes. So these were the results. So on the x-axis, I have the size of the small slice of the data from the 4th country that we are using to estimate the misclassification matrix. On the y-axis, I have the cause-specific mortality fraction accuracy. The green line is the performance of the calibrated method. And of course, it varies as the sample size of the misclassification matrix. The sample size of the data used to estimate the misclassification matrix varies. The blue line is the uncalibrated CSMF, and the red line is the calibrated CSMF when using the misclassification matrix also trained on the other 3 countries, not using any of the local data. So as you can see, when the sample sizes are very small, the green line kind of coincides with the blue line, which is kind of expected. That in absence of any evidence, our Bayesian model shrinks the estimates towards the raw estimates. But as you can see, as we have, even like at 100 sample size for the misclassification matrix, we get considerable improvements over the blue line for most of the countries, and at 200 and 300, at 200 and 400 sample sizes, we get quite a big improvement for most of the countries. If you look at the gap between the green and the blue lines, the red line is like calibration based on misclassification matrix estimated from the other 3 countries. This one performs a little bit erratically. Sometimes it does better than the blue line. Sometimes it's much, much worse. So that just shows there's a lot of heterogeneity in the error matrices across countries. And this is an important point for the project going forward. Going back to Lee's question, how to combine information from multiple VA algorithms. So what we have is an ensemble VA calibration that incorporates multiple algorithms. So if we just look at each algorithm separately, we have their own misclassification matrix and their own raw or uncalibrated CSMF, and we can do the calibration separately and get the calibrated CSMF for that algorithm. We can do that for in silico VA, we can do that for EAVA. These were the two algorithms we were considering for COMSA. And the issue with that is this will give us two different estimates, and then we have to pick which one is the better estimate. And if you look at the literature for autopsy, every paper on a new method comes out, they say they are the best method and they beat the other method. So it's hard to tell which is the best estimate a priori. So what we do in the ensemble calibration is that we still use the algorithm-specific error matrix, like this is the in silico error matrix, there's the in silico raw CSMF, this is the EAV error matrix, there's the EAV raw CSMF, but we connect them to the same true CSMF as our unknown in the law of total probability. So we don't solve for two different estimates, but we say we have two pieces of data that they're both informing about the same underlying quantity. And so we use all of the data to solve for the common, for a common estimate, and which we call the ensemble calibration. In absence of any data, any data on the misclassification rates, the ensemble calibration becomes just the average of the raw estimates from the algorithm. So if you're using two algorithms, it just becomes sum of the two divided by 2. But in presence of the misclassification rates data, it is going to weight the algorithm that has less misclassification more, because that is a better algorithm. So it's a data-driven way of combining the misclassification rates from multiple algorithms. So this is the validation of the ensemble calibration on the PHMRC data. So there were 4 individual algorithms: in silico VA, inter VA, naive-based classifier, and tariff, and then the ensemble that combined all 4. And ensemble is the orange or red line. And as you can see, that at moderate sample sizes, it is usually, the red line is usually at the top. So it's either the best or at par with the best performing method. And we don't know which is the best performing method in our COMSAS analysis. So here, since we know what the true CSMF was, we can see what the best performing method is. But in general, it will vary from country to country. As you can see here, naive-based classifier is the best. Here in Mexico, in silico VA is the best. And so you can see that the ensemble generally aligns itself with the better performing method. So you don't have to choose a priori which algorithm to use. You can, as long as there are reasonable algorithms, you can use all of them and put them in the ensemble calibration. Then going back to your question about the which cause to use. So MITS, as I said, has both an immediate cause and an underlying cause, and it gives us the entire causal chain. We were initially just pairing the underlying cause of death to the VA cause of death because VA predicts the underlying cause of death. But talking to the CHAMS folks, we realized that there are many cases where they're not certain as which is the immediate and which is the underlying, and the labeling is sometimes arbitrary to a certain extent. And they said it might be better if you use both of them in your calibration, because there's quite a few of the cases where we are not certain. And so the calibration we presented so far only works on a single true cause of death, because the error matrix is formulated based on what each true cause of death is. So the question was how to extend it to use the fact that both the underlying or the immediate cause of death could be the true underlying cause of death. So to do this, what we do is we go back to the single cause MITS, single cause VA setting. Here, for each case, you will have one particular MITS cause. An example, MITS cause is A and VA cause is B. So in the error matrix, the contribution of this case is a 1 in the A, Bth column and zeros everywhere. So this is its contribution to the error matrix. It's very uniquely defined when both MITS and VA are single cause. Now we go to the single cause MITS, but multi-cause VA. Here the MITS cause is A, but the VA predicts 20, 50, 30% for the 3 causes. Here also, the contribution of that case to the error matrix is very clearly defined. Only the 8th row will be non-zero because the true cause is A, the MITS cause is A, and then the VA scores will be 20, 50, and 30 as predicted. So it's, again, in the multi-cause VA single cause MITS, it's very uniquely defined what the contribution of that case is to the error matrix. Now we come to the more like statistically interesting setup where the MITS also has uncertainty and the VA is also multi-cause. And we say like maybe the MITS cause is either A or B. So we now have two scenarios. If the MITS cause is A, this is going to be the contribution of that case to the error matrix, where the Ath row will be non-zero. If the MITS cause is B, then this is going to be the contribution to the error matrix. So the Bth row is non-zero, and that the model basically accounts for both of these, gives them equal weight. Because we talked to the CHAMPS people saying, could you give us weights for the underlying and immediate cause? And they said, no, that's not possible to sort of assign manually weights. So we give them equal weights, but if you have more information, more certainty, you can also give them unequal weights. But currently we give equal weights to both these possibilities to adjust for like uncertainty in the MITS cause of death. And we validated also this method in the PHMRC data. There is no multiple true cause of death in the PHMRC data. So we just created an artificial data where we paired two cases with different true cause of death to create a single case with an uncertain cause of death. And so this is not truly a PHMRC data, but a toy, like a simulation data created from PHMRC. And we saw what the accuracy is when using the true cause of death versus the accuracy when using the ambiguous cause of death. And we generally see quite a good alignment with some noise. So it generally can catch the uncertainty in the MITS cause of death, as long as it's not like super uncertain or spread over like every possible cause. Yeah.
So is your sense that variability and alignment is related to implementation systems for verbal autopsies that vary by country, or hard to know?
The availability?
Yeah, the variability.
Oh, the variability.
So closely aligned in India, it's less closely aligned, say, in Mexico. Do you think that's related to the implementation system for how they train folks?
Yeah, I think a lot of the variability in verbal autopsy data itself is due to the implementation system, because the way the questions are asked and sort of like the local norms of what is like a severe pain versus what is a moderate pain, and those kind of things probably vary a lot between countries. So that leads to the noise in the countries. So now that we have kind of covered every piece of the modeling, just the meta overview of the calibration, we still have two pieces of data: the larger VA data and the smaller paired VA MITS data. We have two algorithms. It can be done with more than two, but here we have in silico VA error matrix and EAV error matrix. And in silico VA error matrix, we get the uncalibrated CSMF for each of them. They are simply given equal weights to get the uncalibrated ensemble CSMF, but then these pieces are also fed into the ensemble calibration to get a single unified ensemble calibration estimate. I'll go over the COMSA Mozambique results. So there were three calibration algorithms: in silico VA, EAV, ensemble. We chose EAV and in silico VA because they're of very different nature. In silico VA is like a statistical classifier. EAVA is more of a like clinical knowledge-driven classifier. It doesn't use any sort of statistical modeling. It uses like a clinical decision-making process. So they are of very different nature, and that's why we wanted to keep both to make sure that the results are robust. We did both single and multi-cause analysis. The results are generally similar, and I'll present the multi-cause one because it incorporates more information, but generally the sensitivities were better estimated when using multi-cause analysis. The data set we had around 2,000 children for the COMSA Mozambique data. We used 7 causes, which are mutually exclusive and sort of taken together, kind of exhaustive. For neonates, there were around 800 neonates, and the 5 causes for neonates. And the CHAMPS VA data that we used to estimate the misclassification matrix had around 430 children and 340 neonates. So these are the results for calibration using in silico VA. This is the error matrix that I had showed before. Here we have the causes on the x-axis, the cause-specific mortality fractions on the y-axis. The red dots are the uncalibrated CSMFs. The black dots are the calibrated CSMFs, and the black bars give the uncertainty intervals, which is also an advantage of the Bayesian method because you get the confidence intervals. As you can see, the main changes are for malaria, after calibration, it goes up, the CSMF goes up, and for pneumonia, it kind of goes down. It's generally hard to kind of directly comment on why this is happening because this is an interaction of all these error rates. But the main point was that if you look at malaria, it was being misclassified. 20% of them were being misclassified as pneumonia, and then another 24% was being misclassified as other infections. And pneumonia and other infections, they combine for a large percentage of cases. So it meant a large percent of malaria cases were being misclassified. So there was a lot of undercounting going on, and that calibrating for that leads to increase in the CSMF for malaria. For pneumonia, if you can see, it has a lot of the causes are misclassified into pneumonia. Like 20% of other infection cases are misclassified as pneumonia. 27% of other, like for every cause, there is a pretty significant percent that's being misclassified. So there are a lot of false positives for pneumonia. So if you account for that, it brings the percentage of pneumonia down. These are the results for EAVA. They're generally similar. The only, again, like malaria, it increases, and pneumonia, it decreases. The only main difference was for other infections, there was a considerable increase after calibration. And the reason for this was, if you compare the proportion of other causes that were being misclassified as other infections, that is this column here, this was much more in silico VA. You can see this column had more like reddish cells than this column, which was much less. And so there was much less number of false positives into other infections. There were more false negatives, like 30% of other infections were going into pneumonia. And so after calibration, it adjusts for that. The ensemble results, which is our final estimate, is roughly the average of the two, but it gives different weights to different algorithms. So for example, the ensemble estimate of malaria aligned more closely with the in silico VA estimate than the EAVA. And if you go back, the EAVA estimate has a lot more uncertainty. You can see very wide bars, whereas the malaria estimate is much more certain. So there's an example of the data-driven weighting that it's doing. So it ends up aligning more closely with the in silico VA estimate, whereas for something like the other infection, this lies more in between the in silico VA and the EAVA because both were sort of equally uncertain. But these were the estimates for under 5 children, other infections at around 35%, malaria around 20%, same for diarrhea and pneumonia around 10%. The rest were contributing to smaller fractions. We could not do CSMF accuracy because we don't know the true CSMF. So what we use is the widely applicable information criteria. It's a data-driven way to assess how good of a model fit you are getting. And when we compare the calibrated and the uncalibrated, the calibrated definitely has lower WAIC for all the algorithms, and lower is better. I'll quickly go over this, the neonate results. The main feature of the neonates was prematurity having a very high sensitivity. It gets almost all the prematurity cases correctly, but then also for all the other cases, especially like infection and EPRI, which are major categories, there is a lot of misclassification into prematurity. So there's not too much false positives for, not too much false negatives for prematurity, but a lot of false positives. And so the calibration, as you would expect, it brings down prematurity quite a bit, and it brings up infection because a lot of infection were getting misclassified as prematurity. And this was generally similar even for EAVA, like infection goes up, prematurity goes down. And in the ensemble, we get the same story. Infection is the dominating cause of death for neonates in Mozambique, followed by EPRI and prematurity. The WAC results were similar. The calibration was much better. So ongoing work, the main assumption that went into the method was that the estimate of the misclassification matrix is reliable. It's based on the CHAMS data from the 5 countries, one of which is Mozambique, but there are also data from some of the other countries, and we really don't know whether we can really use that data. So like the main focus of the new grant is to assess for country or site-specific heterogeneity in these misclassification matrices. And if there is heterogeneity, which based on current findings, there definitely is, how to sort of get a robust misclassification matrix that sort of adjusts for country-specific noise and just keeps the part that is common across countries. And hopefully we can get to that, and then we can use that to extrapolate and calibrate VA-based mortality estimates in other studies. I'm very excited to work with Liu on this CA code project, where we can use these misclassification matrices as an input and calibrate the CSMS from VA studies. Another methodological piece is that we just don't get one single misclassification matrix. We get like a fully Bayesian estimate. So we have the uncertainty, how to propagate that in the when it is used in downstream analysis. There are also a few methods pieces, like the calibration doesn't work for subgroup specific data. So it only works for the whole data. So to sort of have a consistent method to downscale the calibration to sex-specific estimates or subnational estimates, that's another goal. Using just the summary data, not individual data, can we do the calibration? That's another future project. And also, we kind of compress the causes into broad set of causes, like the 7 causes for children and 5 causes for neonates. That's a limitation. The uncalibrated CSMS is at the full resolution of causes. So how do we kind of also go to the same resolution of output as the uncalibrated CSMS? That's another line of work going forward. That's it. These are the papers. The 2 are the methods papers, the single cause and the multi-cause. I have not updated this citation. This is now published in JASA. This is the R package, and these are the 3 papers coming out of based on the COMSA analysis. Thank you.
Well, thank you so much. I mean, this is one of the few statistical presentations I've heard that is really great at actually breaking down very complex concepts into little dummy person. I found that really useful to understand. So any questions from the audience in the room? I guess, we always give priorities to students. Anything that we haven't quite asked yet? If not, maybe faculty members as well. We'll have. Yes,
Abhi, thank you so much for your excellent presentation and working on this area. It's an extremely important area and probably neglected in the sense that we're still struggling not only for the mortality but also for morbidity. I'm a little bit curious about your sampling for the MITS. Okay, if the sampling was from the population level or from the hospital, and how that will affect the so-called verification bias?
Yeah, that's an excellent question. To my understanding, the sampling for MITS was somewhat of a convenient sampling, in the sense MITS is a very, it takes a tissue sample from the deceased children and neonates. So it was very hard to get consent and stuff like that. So it's only for the cases that got consent. And so the cost distribution in the marginal cost distribution in the MITS data is not reflective of the cost distribution in the population data, because as I said, the sampling is not a random sampling. It has a lot of preferential aspects to it. The calibration doesn't make that assumption that the MITS cost distribution is same as the population cost distribution. The only assumption it makes is the errors of VA that we are seeing in the MITS data is same as the errors of VA we would see if we had done MITS on every individual in the population. That is still an assumption, and that's something that's part of the reason we're doing the heterogeneity analysis, to understand how robust those errors are when we look at different sites or different countries. But it's a less severe assumption than assuming the MITS distribution is same as the population distribution. Then you would just simply use the MITS distribution as your estimate, but it certainly is definitely not going to be a good estimate. It's going to be very, very biased.
Initially when we presented, I really thought that because it would be convenient to get it from the hospital.
Yeah.
Okay, and the hospital distribution will be different from the population distribution.
Absolutely.
And that probably could.
Yeah, and even for the error rates, we kind of made some exclusions to the data to make sure some aspects of the error rates that are not transportable to the general population, is kind of removed. So for South Africa, for neonates, there were a lot of nosocomial infections. And so we kind of removed those neonatal data in South Africa because those were not going to be representative of what we see in the population. So we made some of those things, but as you correctly point out, there's a lot to do. In general, it would be ideal if the MITS distribution was similar to the population distribution, but there is no guarantee that is going to happen because it's a very complex sampling process for the MITS. So yeah, it's still a long way to go to have improved estimates. Yes.
Where they are thinking about integrating verbal autopsy into the similar information system because of what you say is not great. So I guess what are based on these findings, what are your thoughts on
well, to say it to be very honest, just the raw verbal autopsy estimates is not very reliable. It's we have seen this for every algorithm we tried for both the COMSA data and the PHMRC data. There is very high misclassification percentage. So if just the verbal autopsy is being done, I guess it's better than not having data. But if there is some way to validate how accurate the VA is for that country or that region, then you can kind of adjust and calibrate. So if there's also a small labeled data collected where there is a physician certification or some autopsy done that you can use to estimate the rates, misclassification rates, and adjust for it, that would be ideal. Or what we are hoping to do with Liu is sort of, if we can see some of the misclassification rates are robust, then we'll use these to extrapolate to other countries which has only VA and no other comprehensive cause of death information. But just going with the VA based on the high misclassification we see, yeah, it's a little problematic. But it's definitely useful in the sense that it's more data than not doing anything. But I think there needs to be accounting for the misclassification of VA.
Can I ask a sort of a follow-up question, I guess, on Sakin's question? So I guess maybe a quick comment first, which is the PHMRC gold standard is actually primarily based on hospital data. But I think, the MITS is one step further, more selective in the sense that, as Abhi mentioned, that there's self-selection into agreeing to either do autopsy or MITS as well. So there's that cultural, personal preferences and selective processes, and maybe are even related to causes of death as well, which I think probably actually need more qualitative studies to better understand. And I think none of these have actually been uncertainties or generalizability actually related issues have been incorporated into the estimates yet.
No.
But my question is, so you did mention that in the MITS publication, there has, so they show that there's 75%, I guess, validity, sensitivity or specificity about between diagnostic autopsy and MITS. Has that been taken into account in the current metrics that you have been developing somehow, or is that possible?
We have not taken into account there. So as I said, in this one, we kind of think of MITS as the gold standard. And so the estimates we are getting after calibration is what you would get had you conducted MITS on every deceased person in the population. But that itself could be biased, as there's only 75% concordance, which is great, but it's not perfect. So if we can also get a misclassification matrix for the MITS based on full autopsies, then we can kind of combine the two and sort of calibrate to a better gold standard. But yeah, I don't know if that's such a data is a cost-specific MITS accuracy. It's generally hard to get because the whole purpose of doing MITS is avoiding full autopsies, and so.
That would be look hard and talk to the foundation.
Yeah.
That might be not impossible.
Yeah.
Yeah, there's one more question.
Oh, yeah. So based off of kind of what we went through and just the amount of work that it seems like needs to go into a verbal autopsy, right, with the amount of questions, wouldn't it be better to transition to something like that's project on a smaller number of people has generalized?
Yeah, I think that's what probably the different MITS projects are trying to do. I think the MITS project is expanding to a certain extent, but at the scale at which VA is done, I think it's not very possible to do MITS at that scale, because that's also probably a very expensive process. I'm not very sure, but also there is the cultural aspect, and there is a lot of hesitation of like going through the MITS process because it takes a tissue sample and stuff like that. So yeah.
Abby, there's a question from
Oh.
the chat about COVID. Want to read it?
Yeah, the question is, there's been a lot of discussion about delayed COVID-related disability and death. Is there room to account for COVID in mortality classification systems? How would you recommend including or not including COVID into a complex modeling process like this? That's a very good question, and probably a very hard question for me to answer. We had discussed COVID at some point in COMSA. I do not recall what the recommendation came out of that, but at least in the current set of estimates, we did not do anything separate for COVID. But if it's another cause that is going to be there in both the VA data, if the VA questionnaires are kind of sufficient to identify COVID separately from like infection or other things, and I'm sure the MITS can identify COVID because they're doing a much more comprehensive set of tests, then we can easily have COVID itself as a single cause and sort of augment the misclassification matrix with a row and column for COVID and get cost-specific estimates for COVID. But the problem, I think, is also like comorbidity issues with other causes that complicates things. So I don't have a good answer to the question, but I hope I was able to give some information.
If I may add to that, so I think the latest WHO VA questionnaire, which is I think the 2021 or maybe 2020 version of that, actually does have the COVID module added to that, and I think there is maybe a separate COMSA grant that actually has that component.
Yeah.
Included. That said, however, I mean, today's presentation is focused on under 5, and as many of you, that COVID has not been a major life-threatening, mortality, sort of inducing infection quite yet. And of course, this varies by country, but so far from the global perspective, and with very limited data coming from low-income countries, we haven't quite seen huge noticeable impact on mortality for under 5. That said, I think if as Abby mentioned, that if CHAMPS and MITS can actually pick up more COVID, and with the new 2020 VA instrument applied, there definitely could be a possibility to work further on this.
Yeah, I think for these set of estimates that I present, it's also using the 2016 verbal autopsy tool. I don't know if it had the ability to diagnose COVID based on the questions answered. Yeah, so.
Okay, any other questions?
Yeah.
Yes.
So talking about COVID, I'm of the situation. So COVID is kind of like a population level pandemic, but there are still people got rare diseases. So I'm wondering about the VA capture the accuracy of the VA capture those rare diseases in and the rare disease may not exist that often in the child population, but for the adults, especially in the older adults population, how accurate is this method of work to capture the rare disease?
So for rare diseases, one of the problems is we are generally grouping diseases into broad categories. And the reason we need to do that is we need to estimate the misclassification rate. So if we have the full 30 plus set of causes, we end up with a misclassification matrix, which is 30 cross 30, which has 900 cells. So it's impossible to estimate that. So that's the statistical challenge of estimating like a rare disease. It will be generally, there will be too few cases to have a reliable estimate of the misclassification rates for the rare disease. And that's why it's probably getting grouped into other broad categories. Also for adults, there are no MITS. MITS is only done for like children and neonates. I think there are some plans of doing adult MITS based on my conversations, but I don't think there is any right now. So you would need some other source of gold standard information to do that as well.
If I can add, rare disease, it really depends on the signs and symptoms and how unique those are. So VA is, entirely ascertaining cause of death based on signs and symptoms. I remember actually very vividly going to the first VA Congress And this is where the PHMRC data were published and released. And actually, out of all the causes, they showed the best, the most valid cause is actually snake bite. Because, it's a very uniquely identifiable, condition. It's also a rare disease, I'm assuming. So it's actually not impossible to identify that. But, for a lot of the infectious causes you saw here, for example, Abby has showed a lot of, information that, other infections is very hard to diagnose. And because a lot of those conditions are like, are subject to very general, like, conditions such as, high fever, and fatigue or what have you. And it's really hard to say, okay, whether it's other infection or pneumonia or, sepsis, for example, among illness specialists. So it really depends on, how unique the signs and symptoms are. And, then VA can or cannot actually pick it up.
Thanks. Yes.
So kind of combining with what you just said with the COVID question, right? So COVID kind of, and I'm not as familiar in like pediatric manifestations or even like the updated, right, in the variants. But COVID started having some symptoms that were like pretty unique, right? Like loss of taste, loss of smell. But that's kind of like shifting away from that. So now I think the symptoms are much more like,
Yeah, it's also variant specific.
so like, would you think that maybe, but if anything, could kind of really throw in a lot of like variability and could like confound things at all because of how like general the symptoms are now? Or is that like not a concern?
Are you aware of any?
I'm not
Validation
sure what they
study?
put in the new module, like what exact questions. I'm sure the smell and test would be part of that, but I don't know what other questions. But yeah, I certainly agree with you. And I think there needs to be proper validation of like including COVID in there, like how accurate is the VA. If it worsens the accuracy, then it's probably not good news. But yeah, I agree with you that if there are symptoms that are common to many different diseases, that's definitely problematic. As Lee said, like the VA can only identify things that are kind of unique combinations of symptoms. So if that's not the case, then it becomes hard.
Cool, great. Well, you can join me in thanking Dr. Datta again for that.
Thanks everyone for attending.